This class is about drugs for heart failure. So, what is heart failure? It is a clinical syndrome caused by the inability of the heart to pump sufficient blood to meet the metabolic needs of the body. So, the heart failure can be due to ventricular filling defect, which we call it as diastolic dysfunction, or defect in the myocardial contractility, which we call it as systolic dysfunction. The leading causes of heart failure are coronary artery disease and hypertension. The other causes are valvular diseases, cardiomyopathy, viral infections, toxins, and certain drugs. The primary symptomatology of heart failure, you can divide it into two major reasons for the symptoms. So, one is due to low output, or we call it as forward failure symptoms. So the patient will present with fatigue, dizziness, muscle weakness, and shortness of breath. And the other set of symptoms are due to increased filling pressure or backward failure due to congestion of the organs. So it may present as peripheral edema or pulmonary edema, maldigestion due to congestion of the gastrointestinal tract, and ascites. This is the pathophysiology of systolic heart failure. So you can see there is decreased cardiac output because of systolic dysfunction, which may lead to decreased blood pressure and decreased organ perfusion. So this triggers the compensatory mechanisms. It increases the sympathetic nervous system drive. It activates the renin angiotensin aldosterone system as well as vasopressin. And again, it activates the atrial natriuretic peptide and brain derived natriuretic peptide. So all these are compensatory mechanisms. So because of this, there is increase in the heart rate, increase in the force of contraction and blood pressure. So this may try to increase the cardiac output for a short period of time. And also this compensatory mechanism cause vasoconstriction, thereby increasing the afterload and preload, and also decreased renal perfusion and sodium retention and water retention. And this may further trigger the compensatory mechanism causing vasoconstriction. So all these are deleterious to the myocardial function. Okay, so this will it will cause a decrease in the myocardial contractility. The workload will be more for the already failing heart. So this compensatory mechanism, it forms a vicious cycle. Okay, so thereby damaging the myocardial function in the long run. And again, these increased activation of sympathetic nervous system and renin angiotensin aldosterone system, it will cause cardiac myocytes hypertrophy. It causes apoptosis, fibrosis, and arrhythmias. So this may further decrease the cardiac output and aggravate the heart failure. So you have various drugs which acts at different steps in the pathophysiology of the systolic heart failure. So this we will see at the later slides. And this is the pathophysiology of diastolic heart failure. So here it is mainly due to the associated comorbid conditions like hypertension, diabetes, coronary artery disease of microvessels, and obesity. So all this will lead to cardiomyocyte hypertrophy and stiffening of the cardiomyocytes, interstitial and perivascular fibrosis. So this may eventually it cause a defect of diastolic relaxation. So the cardiac muscle becomes stiffened. So there will be decreased diastolic filling. Okay, so this may lead to reduced reserve, regulatory reserve, which may again cause pulmonary congestion, peripheral congestion, and decreased output. So here the main mode of management is treating the precipitating factors like management of hypertension, and you can give drugs which reduce the cardiomyocyte fibrosis and hypertrophy by decreasing the workload. And you can give diuretics as a symptomatic management when congestive symptoms appears. So heart failure can be classified into stages. So you have two types of, the main classification we have. So one is New York Heart Association stages. So class 1, we call it when there is left ventricular dysfunction but there is no symptoms of heart failure. And class 2, symptoms at medium to high levels of physical exercise. Class 3, symptoms at low levels of physical exercise. And class 4, symptoms at rest or during daily life physical activities. And we have American College of Cardiology or American Heart Association staging as well. So stage A, patients are at high risk for heart failure but without structural heart disease or symptoms of heart failure. So here the patient have risk factors but they haven't developed heart disease or symptoms. And stage B, uh, presence of structural heart disease but without signs or symptoms of heart failure. And stage C, structural heart disease with symptoms of heart failure. And stage D, refractory heart failure. So there are 5 main principles which we adapt in the management of chronic systolic heart failure. So 1, by neurohumoral modulation. 2, preload reduction. 3, afterload reduction. 4, increasing the cardiac contractility. And 5, heart rate reduction. So neurohumoral modulation is done by using these group of drugs. So I have angiotensin converting enzyme inhibitors, angiotensin receptor antagonist, beta blockers, mineralocorticoid receptor antagonist, and you have a combination of angiotensin receptor blocker and neprilysin inhibitors. So we'll see one by one. So AC inhibitors, so you have been read about these group of drugs already in detail in the previous chapters. Okay, so here we shall just highlight about the role of AC inhibitors in heart failure. So these group of drugs are the first choice of drugs in the management of chronic heart failure. So they act as a vasodilator. They reduce the aldosterone levels, okay, and thereby it has an indirect diuretic effect also. And it has anti-remodeling and sympatholytic effects. So as we saw this angiotensin and aldosterone, they are responsible for cardiac remodeling, like fibrosis, causing fibrosis, apoptosis, cardiac myocyte hypertrophy. So this cardiac remodeling will have a long-term effect on the failing heart. So this AZ inhibitors, they prevent the remodeling of heart. And the main adverse drug reactions, you all know, it causes dry cough, hyperkalemia, angioedema, and it is teratogenic. And this is contraindicated in bilateral renal artery stenosis. The next group of drugs, angiotensin receptor blockers. So you have many drugs like candicertone, eprosartan, irbesartan, losartan, telmisartan, valsartan, etc. So these drugs are used only in cases of intolerance to ACE inhibitors. Suppose the patient develops cough or hypersensitivity reactions like angioedema, then you can go for ARBs. So otherwise ACE inhibitors are the first choice of drugs. And the role of beta blockers in heart failure. So you have only 4 beta blockers which are used in heart failure. They are metoprolol, bisoprolol, nebivolol, and corvidolol. So why beta blockers? What is the rationale of use of beta blockers in heart failure? So we all know the adrenergic overstimulation, okay, which is triggered as a compensatory mechanism in heart failure. It increases the energy consumption of the heart and it causes fibrosis, arrhythmias, and cell death. So it causes cardiac remodeling as well. So that is why we use beta blockers. And for which group of patients beta blockers are used? So they are used only in symptomatic heart failure and after myocardial infarction. And it is not to be administered in new onset or acutely decompensated heart failure. Okay, so because it will further precipitate heart failure symptoms. So it should not be administered in a new onset or acutely decompensated heart failure. So how to administer this beta blockers? It has to be started at a very low dose. So 1/8 of the target dose has to be started first, and then slowly the dose has to be escalated, okay, doubling every 4 weeks. The next group of drugs, mineralocorticoid receptor antagonists. So you have spironolactone and eplerenone. So these are potassium sparing diuretic. They also act as an aldosterone antagonist. It causes hyperkalemia, and it is given in low doses to patients with symptomatic heart failure. So only in symptomatic heart failure it is given in very low doses. So the guidelines of mineralocorticoid receptor antagonist administrations, uh, you should not administer more than 50 milligrams per day, and these drugs should not be used if the GFR is less than 30 ml per minute. So you have to be careful in diabetic patients because of higher risk of hyperkalemia, and these drugs should not be combined with NSAIDs and potassium sparing diuretics. The combination of angiotensin receptor blocker valsartan with neprilysin inhibitor sacubitril, it is being recently used in the management of chronic heart failure. So neprilysin, it is an enzyme which breaks down the natriuretic peptides. So an neprilysin inhibitor, it blocks the breakdown of natriuretic peptides, so which causes vasodilation and diuresis. And valsartan, it is an angiotensin receptor blocker. So this lowers the combination lowers the vascular resistance, and it increases the blood flow. The next principle is preload reduction. So this is done by using loop diuretics, thiazide diuretics, potassium sparing diuretics, and nitrates. So by reducing the preload, we are decreasing the workload of the failing heart. So loop diuretics, you have bumetanide, furosemide, torsemide. So these are used in the symptomatic treatment of severe heart failure. When the patient has severe edema, okay, severe congestion, then you can use loop diuretics. And thiazide diuretics, they are used as combination therapy with loop diuretics only in refractory cases. So loop diuretics are the preferred diuretics in the relieving congestive symptoms in heart failure. And potassium sparing diuretics can be used in combination with thiazides or loop diuretics to reduce the potassium and magnesium wasting. And next principle, afterload reduction. So this is done by arteriolar dilators like hydralazine plus nitrate combination, sodium nitroprusside. And the combination of hydralazine and nitrates, they are used in cases of renal insufficiency or renal artery stenosis who cannot tolerate ACE inhibitors. So it has only a limited role in the heart failure management. The next principle of treatment is increasing the cardiac contractility or inotropic agents. So here you have cardiac glycosides, catecholamines, dobutamine, phosphodiesterase inhibitors, and calcium sensitizers. This is the site where the inotropic agents act. So this is the excitation, contraction, coupling which is happening in the sarcomere of the cardiac myocytes. You can see here. So when the action potential arrives, there will be influx of sodium and calcium into the cytosol. So this calcium will again in turn trigger the release of calcium which is present or which is stored inside the sarcoplasmic reticulum. So this calcium will be released out into the cytosol through the ryanodine receptors. Okay, so the calcium which comes inside will trigger the release of calcium which is stored in the sarcoplasmic reticulum, thereby increasing the cytosolic calcium level. So this binds to the troponin C, which causes the actin-myosin interaction and causes contraction of the cardiac myocytes. So you can see here. So after the contraction, this calcium will be again taken back into the sarcoplasmic reticulum, through a through an calcium ATPase called as SERCA. Okay, so this is the sarcoplasmic reticulum calcium ATPase, which is responsible for this driving back the calcium from the cytosol into the sarcoplasmic reticulum. And again, there is a presence of sodium potassium ATPase and sodium calcium exchanger and calcium ATPase. So sodium potassium ATPase is responsible for the efflux of sodium out and influx of potassium inside. So after the action potential is over, the sodium which is excess sodium which is present in the cytoplasm will be removed by this sodium potassium ATPase, and similarly the excess calcium will be removed through the sodium calcium exchanger. Okay, so one calcium ion will be removed in exchange with 3 sodium ions. And again, calcium ATPase present in the membrane is also responsible for removal of the excess cytosolic calcium. So all these actions will bring the cardiac contraction to an end. Okay, so here we have different drugs which act as a positive inotropic agent. So one of the important drug is the cardiac glycosides, digoxin. Okay, so this drug will act at the, it will inhibit the sodium potassium ATPase enzyme. So this inhibition will cause more sodium to get accumulated inside the cytosol. Okay, so more sodium inside will again it will block the sodium calcium exchanger. Okay, so thereby it decreases the efflux of calcium. So since there are more sodium inside, this calcium sodium calcium exchanger will not work, and there will be increased in the cytosolic calcium level, which may lead to increased myocardial contractility. So this is the mechanism of action of cardiac glycosides. And you have other group of drugs called as phosphodiesterase inhibitor. So what these drugs do? So before knowing about this, you have to know that the cyclic AMP, when this increase in the cyclic AMP will cause increase in the protein kinase A level. This in turn phosphorylates a protein called as phospholamban. So this phospholamban will have a chronic inhibitory effect in the SERCA. So when in the unphosphorylated form, it inhibits this SERCA. Okay, but once it gets phosphorylated, so this inhibition will be lost and more calcium will be taken back quickly inside the sarcoplasmic reticulum. So this will cause quick relaxation of the myocardial quick relaxation of the myocardium, and also more calcium will be available for contraction when the next action potential comes. Okay, so the drugs like catecholamines, which acts via the beta receptor, will cause increase in the cyclic AMP level, and also the phosphodiesterase inhibitors will inhibit the phosphodiesterase 3 enzyme, which is responsible for the degradation of or metabolism of cyclic AMP. So both these drugs will increase the cyclic AMP concentration, thereby phosphorylating the phospholamban. Okay, so these are the mechanisms of actions of various inotropic agents, and we also have calcium sensitizers. Okay, which increases the calcium binding to the troponin C, and by thereby causing the effective myocardial contraction. Okay, so these are the inotropic agents and their sites of action. So the most important group of drug, as I said, is cardiac glycosides. So the British botanist William Withering, so he extracted digoxin and digitoxin cardiac glycosides. So digoxin is the major cardiac glycoside which we use for the management of heart failure. So as we saw, it acts as a sodium potassium ATPase inhibitor. So the points you should remember about these cardiac glycosides are it has very low therapeutic index. So the therapeutic level is between 0.5 to 0.8 nanograms per ml. and it has a very high volume of distribution, and it causes cumulative toxicity, and it is a pro-arrhythmic drug, and the gastrointestinal adverse effects are commonly seen, and these are anorexia, nausea, and vomiting, and CNS adverse effects are headache, fatigue, sleeplessness. So these are the early symptoms of toxicity. It also causes visual disturbances. Management of digoxin toxicity involves stoppage of digoxin abruptly, and when there is extreme sinus bradycardia or sinoatrial block or AV block, then you can give atropine and pacemaker. If the arrhythmia is tachyarrhythmic, like tachycardic ventricular arrhythmias and hypokalemia, then you can give potassium infusion. So you must remember digoxin cause hyperkalemia, okay, because it inhibits the sodium potassium ATPase, so it causes hyperkalemia, whereas hypokalemia aggravates digoxin toxicity. So because potassium and digoxin, they compete for the sodium potassium ATPase, so whenever there is hypokalemia, more digoxin will bind to the enzyme and it causes digoxin toxicity. And you have anti-digoxin immunotherapy by giving purified fat fragments from ovine antisera, so which we call it as digibind. So these are the drugs which we use to manage digoxin toxicity. Okay. So hypokalemia, since hypokalemia aggravates digoxin toxicity, it can be treated by giving potassium infusion. The other inotropic agents are dobutamine, dopamine, epinephrine, and norepinephrine. So they mainly act via beta-1 receptor mediated stimulation of cardiac output. And you have drugs like inoximone and milrinone. So these are phosphodiesterase inhibitors which act by increasing the cellular cyclic AMP level. So it increases the cardiac output and also dilate the blood vessels by this phosphodiesterase inhibition. So they are called as inodilator. And you have a drug called levosimendan. It is a combined calcium sensitizer. Okay, it increases the troponin C binding and also phosphodiesterase inhibitor. So it increases the cardiac output as well as decreases the vascular resistance. So it is also an inodilator. The last principle in the management of heart failure is reduction of the heart rate. Okay, so since increased heart rate means increased workload for the heart. Okay, so heart rate reduction can help in the management. So drugs like ivabradine and beta blockers can be used for this purpose. Ivabradine, so this you must have learned in the angina chapter. So ivabradine, it is a selective inhibitor of cardiac pacemaker channels causing bradycardia. So the adverse effects are visual disturbances, bradycardia, atrial fibrillation, and QT prolongation. So that's all about the principles in the management of heart failure and various drugs which we use for the purpose. And to summarize the management of chronic heart failure according to the stages. So stage A, we use AC inhibitors or ARBs, and management of risk factors and lifestyle modifications. Stage B, again AC inhibitors or ARBs, can give beta blockers in appropriate patients. Stage C, when the ejection fraction is preserved. So when the ejection fraction is more than 45, then you can give diuretics. And when the ejection fraction is reduced, when it is less than 45, you can give diuretics in combination with ACE inhibitors or ARBs, ARNIs, beta blockers, aldosterone antagonist, ivabradine. So combinations can be used. And in reduced ejection fraction, in selected patients, you can give hydralazine, nitrates, and cardiac glycosides. And in stage D, which is a refractory heart failure, you can go for advanced care measures like heart transplant, chronic inotropes, necessitide, temporary or permanent mechanical support. So these can be given. So acutely, so till now we saw chronic heart failure. So acute decompensated heart failure can be precipitated by acute myocardial ischemia, uncorrected high blood pressure, arrhythmias, pulmonary embolism, kidney failure, non-adherence to medication, sodium and fluid restriction, non-adherence to sodium and fluid restriction, negative inotropic drugs like verapamil, diltiazem, beta blockers, and nifedipine, NSAIDs and COX-2 inhibitors. So all these are precipitating factors which may cause acute decompensated heart failure. So management of acute heart failure is by giving diuretics, mainly intravenous furosemide, vasodilators like nitroglycerin and nitroprusside. These are avoided in patients with systolic blood pressure less than 110 millimeters of mercury. Then you can give positive inotropic agents like continuous dobutamine infusions or epinephrine or epinephrine or dopamine. Then phosphodiesterase inhibitors like milrinone and enoxaparin can be used, and calcium sensitizers like levosimendan and pibomentan. So that's all about management of chronic heart failure and acute decompensated heart failure. So here we saw only about management of systolic heart failure. Okay, so you must remember AC inhibitors or drugs of choice in the management of chronic heart failure in the earlier stages. Okay, and beta blockers should be cautiously used only in the symptomatic patients. And again, loop diuretics are mainstay in the reducing the congestion in the heart failure patients. So these are the drugs you should remember. And digoxin is the important inotropic agent which is used in the later stages of heart failure, and you must know about the mechanism of action of digoxin. And management of acute heart failure, it involves use of loop diuretics and inotropic agents. And you must remember the precipitating factors of acute decompensatory heart failure. Okay, thank you.